Hey everyone, welcome to this explainer on Etosaban, or as you might know it, Savasa. Today we're literally slicing right through the complex prescribing data of this high-alert direct oral anticoagulant. The goal? To give you a sharp, highly actionable clinical edge. Look, whether you're prescribing, monitoring, or managing complications, anticoagulants are incredibly high stakes. So let's get perfectly aligned on how to use this drug safely and effectively straight from the clinical source material.
Okay, so here's our structured roadmap for today. We're going to hit 1. The black box warnings. 2. Indications and standard dosing. 3. Navigating kidney function adjustments. 4. Critical drug interactions. 5. Managing special patient populations. And lastly, number 6, bleeding risks and reversal. Let's get into it.
Part 1. The Black Box Warnings. Uncovering the Unexpected Risks of Edoxaban. We're starting right out of the gate with the absolute most critical and, honestly, kind of counterintuitive, life-saving info you need before you even think about writing a prescription. So think about this question for a second. Can too much kidney function actually be a bad thing? Now, usually we're worried about poor kidney function causing a drug to, build up to toxic levels. But with Edoxaban, the answer is a resounding yes. It sounds completely backwards, right?
Well, here's the deal. In patients being treated for non-valvular atrial fibrillation, a creatinine clearance over 95 mL per minute actually carries a U.S. boxed warning. Why is that? Because the ENGAGE-AF TIMI 48 study showed that hyper-efficient kidneys just clear the drug out way too fast, and that actually reduces the drug's efficacy, which leads to a higher rate of ischemic stroke compared to patients on warfarin. Basically, if your AFib patient has a creatinine clearance over 95, you absolutely should not use Edoxaban.
And that perfectly sets up our second major red flag. You need extreme vigilance around neuroaxial anesthesia. We're talking about the risk of epidural or spinal hematomas in patients on Edoxaban who are undergoing spinal procedures. This is a huge deal because these hematomas can cause long-term or even permanent paralysis. And that risk is amplified big time by things like indwelling epidural catheters, concurrent NSAID use, or a history of spinal surgery. You have to meticulously monitor these patients for literally any sign of neurological impairment.
All right, moving on to Part 2. Indications and standard dosing. Applying the rule of 60. With those vital red flags clearly marked in our minds, let's transition to the standard clinical applications and see how the daily pathways build out from here.
Now, what's really fascinating here is the stark contrast in how you initiate this drug depending on your target. If you're treating atrial fibrillation, it's pretty simple. You start the patient immediately at 60 milligrams once daily. Boom, done. But if you're treating a deep vein thrombosis or pulmonary embolism, a VTE, you can't just hand them a pill on day 1. VTE treatment actually requires at least 5 days of initial therapy with a parenteral anticoagulant like heparin before you can safely transition them to Edoxaban.
For both of those indications, there is one thing you absolutely must remember: the rule of 60. If your patient weighs 60 kilograms or less, their systemic exposure to the drug goes way up. Because of that, you have to drop that standard 60 milligram dose down to 30 milligrams once daily. Weight matters immensely with this medication, so don't overlook it. And look, switching anticoagulants isn't a guessing game, right? It requires absolute precision. So if they're on low molecular weight heparin, you want to start Edoxaban within 2 hours before their next scheduled shot.
Transitioning from a continuous unfractionated heparin drip, start the Edoxaban right when you turn that infusion off. And if they're coming off warfarin, you have to hold off and wait until that INR drops to 2.5 or lower before starting.
Okay, part 3. Navigating kidney function adjustments. The essential renal algorithm. Like we've already seen, renal function strictly dictates DOAC dosing. Treat this next section as an unbreakable clinical algorithm for your daily practice. I highly recommend taking a mental snapshot of these numbers, because they dictate exactly when to reduce the dose and when to just avoid Edoxaban entirely. For AFib, remember, we avoid it if clearance is over 95. The absolute sweet spot for the full 60 mg dose is a clearance right between 50 and 95. Now, if that clearance drops to between 15 and 50, you've got to reduce the dose to 30 mg. And if it drops below 15, or if your patient is on dialysis, you just avoid it completely. It's simply not recommended.
Part 4. Critical drug interactions. Watching out for P-glycoprotein inhibitors and bleeding risks. Since Edoxaban is a major substrate of P-glycoprotein, we really have to look out for specific medications that can dangerously alter its concentration in the blood. Let's dive right into these major PGP inhibitors. If you are treating a VTE patient, combining Edoxaban with any of these heavy hitters, things like macrolide antibiotics, verapamil, or oral antifungals like itraconazole, that requires an automatic dose reduction down to 30 mg daily. What's kind of wild here is that the guidelines note this specific dose reduction applies to VTE patients, but no dose adjustment is actually recommended for atrial fibrillation patients on these same interactors, though obviously you still need to monitor them heavily for bleeding. All right, part 5. Managing special patient populations, navigating the edges of clinical practice. Look, we all know not every patient fits neatly into a standard textbook case. So let's navigate the edges of clinical practice and look at how to manage special populations, starting with obesity.
According to the International Society on Thrombosis and Hemostasis guidelines, the crucial takeaway here is to generally avoid DOACs like Edoxaban in patients hitting extreme obesity thresholds. We're specifically talking about a BMI over 40 or a weight over 120 kilograms. The reason is pretty straightforward. There's just a significant lack of clinical data on efficacy in this specific population. If you absolutely must use it, guidelines recommend measuring antifactor XA levels, and if those levels are off, switch to a vitamin K antagonist instead of just guessing with dose adjustments.
Furthermore, surgeries that alter gastric pH or decrease the surface area of the small intestine, like a Roux-en-Y gastric bypass, can critically reduce the drug's absorption. These tablets literally need an acidic stomach environment to break down properly. Also, when it comes to pregnancy and breastfeeding, Edoxaban is a strict no-go. There's a known risk of fetal bleeding, and honestly, it just isn't known if the drug passes into breast milk. So you definitely must switch these patients to an alternative anticoagulant. Section 6. Bleeding risks and reversal. Handling the ultimate complication. Let's move to our final section and tackle the ultimate, unavoidable risk of literally any anticoagulant out there: severe hemorrhage. Keep in mind, hemodialysis won't clear this drug effectively, and your standard reversal agents like vitamin K or protamine sulfate, totally useless here. So, when you are facing a life-threatening bleed, this is the exact name you need to have locked in your brain: andexanet alpha. This is a specific reversal agent that essentially acts as a decoy to bind and sequester factor XA inhibitors. When your patient is bleeding severely and every single second counts,
This is the targeted agent you need to consider.
But let's be real, what if andexanet alpha just isn't available in your formulary or pharmacy at that exact moment? Well, your emergency backup weapons are the 4-factor prothrombin complex concentrates. You can consider using unactivated PCCs like Kcentra or activated PCCs like FIBA. These are going to help urgently restore hemostasis by providing a massive influx of clotting factors to just overwhelm the inhibitor's effects.
Of course, the absolute best way to handle bleeding is to prevent it in the first place, right? Especially during elective procedures. You have to meticulously time the discontinuation of Edoxaban, and this timing is based entirely on the patient's creatinine clearance. If it's 30 or above, stop the drug 24 to 48 hours beforehand. If it's below 30, you need to give it 48 to 72 hours to clear their system. And whatever you do, don't rush to restart it. Wait at least 24 hours post-op, and do so only once you have confirmed absolutely adequate surgical hemostasis.
As we wrap up this explainer, I really want to leave you with this final provocative thought. How do we confidently balance the life-saving necessity of anticoagulation against the persistent underlying risk of catastrophic hemorrhage? Well, it's by relying on the exact clinical parameters, those kidney function algorithms, and the strict transition rules we've walked through today. Thank you so much for joining me for this deep dive into the data, and I'll catch you in the next explainer.